Spin Essentials, the core topics in pediatric neuroimaging essential for daily practice, packaged as our holiday gift to you.
Hello, my name is Jess Cooper. I'm the MRI Superintendent Radiographer at Great Ormond Street Children's Hospital. I'd just like to begin this talk by thanking the SPIN organisation for this incredible opportunity to present this talk today. It's an honour as a radiographer to be able to participate in learning at this level and to be included in such an open and collaborative education and teaching forum like SPIN is. I'm really sorry I can't be there in person today. So the talk I'm going to be giving is on common MRI artefacts, and without further ado, let's get started. So what is an artefact? The Oxford Dictionary defines it as an object made by a human being, typically one of cultural or historical interest. It's all very true. That is not the type of artefacts we're talking about today. Those artefacts belong somewhere like the British Museum. Today we're going to be talking about MRI artefacts. In the medical dictionary, this is a definition of an MRI artefact: an artificial project, structure, appearance that is not natural due to manipulation or distortion or fuzziness of an image caused by manipulation. And that is what we're going to be referring to today. So what is the problem with artefacts? Now, some of the main issues we can come across are they can be confused with pathology and cause false positives. They can also conceal something underneath or behind this artefact and could cause a wrong report. It may indicate a problem with some hardware, so a fault with the RF shielding, for example, or also software fault, a problem with the misregistration, or a fault within your equipment. And finally, it can reduce the overall quality of the examination. It is important to be aware of these artefacts when they appear and how we eliminate them. And it's also important that sometimes we have to accept them as a known limitation of interpretation. So some of the artefacts I'm going to be discussing: motion. And under motion, we're going to be talking about macroscopic patient motion, which is the bulk gross patient movement that we are all familiar with. And then some microscopic motion, such as respiratory artifact, cardiac motion, blood flow, peristalsis, and also particularly for neuro, CSF and vascular pulsation. Then we have some other examples we can go through involving trunking, aliasing, foreign bodies. I've got some examples to show you, and then some technical aspects. So talking of motion, this is general motion artifact, an example of that main bulk motion, macroscopic motion. First of all, in image A, this is a T1 axial exam that's quite moved, and that pink arrow there is just pointing to some ghosting artifact. So this is an example of where multiple copies of the image is being recorded in the case space as the patient is moving. And also, if you look in the parenchyma, this is also disrupted and is suffering from that ghosting artifact also. Image B is a T2 axial. Now these are more robust because these are usually faster acquisition times and relaxation times are longer in these, so you can also add better acceleration techniques like IPAT and turbo spin echo. Therefore, they tend to be a little bit more robust to that motion artifact. And then finally, in image C is an example of a diffusion image. There is quite a lot of air tissue interface artifact, and then also the motion is included here. So you have some of that ghosting plus the air tissue interface artifact. These scans, although in that area is quite problematic, further up in the parenchyma, you do have a high diagnostic yield because they can be quite quick. So they're quite robust to motion when you're looking at parenchymal image pathology. So they are usually quite good. Moving on to some solutions. So macroscopic motion solutions that we use regularly. We have immobilization aids. So when we position the patient on tables, we can use sponge pads around the head to make sure that there's no air gaps, and that helps to keep them firmly in place. We also use some sandbags around the patient to help keep their legs still. Vacuum cushions are useful for babies, small infants. That helps to keep them tightly wrapped and also restricts the movement. And the straps that we can put across patients on scanner, I tend to refer to them as seat belts. It sort of gives the patients a little bit of reassurance and gives them sort of a reference to something that they're quite usually familiar with. So we just put some seat belts on just to help them keep still. That tends to work quite well. Before they even get on the scanner, good preparation is really key to maximize your cooperation. We have the very good play specialists with us, and you might not have that in your centres. However, radiographers can spend, if they can spend some time going through some preparation, doing some practice, that's really helpful. And we have other things we use, models and inflatables, which examples of which are coming up in a few slides. We also use distraction. It's really great to get the parents on board, have a little chat with the parents, make sure that they're aware of what we're trying to achieve. And then we are lucky enough to have DVD players, which also help to engage the patients and make sure they keep still, gives them something to focus on. They have the power and the choice to choose what film they watch, gives them back a little bit of power of choice, helps with cooperation in that way. So this is just a little example. Unfortunately, we couldn't use a real person, so please excuse our crude mock-up of a patient. So here we have an example of the vacuum cushions that we use. So that plugs into the table in the inbuilt vacuum socket, and then it's sort of like a little bean bag, sucks all the air out, and then that keeps the patient really nice and still and restricted. And then an example of the sponge cushions with the headphones on, that helps to restrict as well. And then the additional sponges, which really helps minimize the amount patients can move. And here's an example of Denise, our wonderful play specialist who works with us regularly in radiology. And we also have lucky enough to have a Lego model which the patient can play with and interact with beforehand, which is really special and really works wonders. And then just a little nostalgic picture in the middle, which we don't use anymore. We also have an inflatable scanner. So this is a copy of our 3T Prisma scanner, and we have it set up in the department, and it deflates and inflates at the switch of a button. It is quite noisy, but that also helps with preparation because the scanners are quite noisy. So even though it's not the exact same noise, you can prepare the patient to be aware that it's going to be quite loud. And it also brings in the element of play. They can jump about in it, go in it, practice lying still, and it's been a really useful tool and has helped to prepare patients. They can sometimes, if they're in the hospital a day before, they can come in, have a go, have a practice. And then we have an example of one of our patients, Olivia, trying it out for us, and she did a brilliant job. And here's our DVD player that we have set up. So we give patients choice of a DVD, and then the screen is placed on the wall right at the end of the ball, so they have the head coil on, or if they're not having their head imaged, we have a separate mirror that goes across, so they can always see the TV, whatever scan they're having. And then the screen then comes on. We can switch the direction of the screen, so whichever way up the mirror is, they'll be able to see in the correct viewing for them, and then they can hear all the sound gets played through the headphones, so they can watch their favorite movie while they're having a scan. It really does help. I know everyone's not lucky enough to have these, but if you are setting up a scanner and you do have that capability, I cannot suggest it strongly enough. It really, really helps us so much. Moving on to some practical solutions for movement. This is an example of blade imaging. So each blade on this diagram on the left demonstrates multiple parallel phase encoded lines that are collected, and these are using a fast spin echo or gradient echo sequence. The blades are then rotated by a small angle, usually about 10 or 20 degrees, at which time a second set of data, a third set of data, a fourth set of data are all acquired. Then this process continues until it's gone all the way around the rotation, and then the image is set out in the K space, and it can rearrange that data to make any movement, smooths it out very cleverly and physically. I'm so sorry I can't explain in any more detail about that, but then we get then the still image. So here on the left of the MR you get a T2 axial, and you can see then a motion corrected T2 axial on the right using the blade sequence. These usually are available on most systems. They do have different names, different manufacturers all have different names, so blade, propeller, multivane, and other less popular brands that also have similar versions. We use these quite regularly for collecting fast data, and to even if we're really struggling to get some still images, even just getting a few sequences using this technique is really valuable to have some idea of any diagnostic or physiological situation that's going on. So it's really, really handy to have in your arsenal. Moving on now, we're going to talk about some microscopic motion solutions. So here we have two abdominal images, and what you can see here is that ghosting artifact. So we have some respiratory motion. The images are acquired in the A to P phase encoding view, and you can tell that by the direction of the ghosting artifact. It will always appear in the phase encoding direction you have set up. A solution to this, you could maybe just switch the phase encoding, so then you could scan right to left. However, a problem in this area and for these scans is you will have your arms by sides, and therefore you will have a problem with aliasing, which we'll talk about a little bit later, and the arms will then appear inside your image. Another solution would be to use some oversampling, so you image slightly wider field of view, and then you cut away the parts where your overlapping anatomy will be, so the arms in this instance. This does have a time penalty, and especially for these type of scans, which a lot of time are breath hold scans, that could be quite problematic for patient cooperation. So how can we tackle this? Some solutions to reduce respiratory artifacts. So first of all, we have correct coil placement. This sounds very obvious, but you'd be surprised how often this doesn't happen. So you want your receiver coils to be directly over the anatomy you're acquiring and positioned as accurately as possible. So for example, if you're imaging the abdomen, you want to get the chest outside of the field of view as much as possible. That could then reduce the cardiac motion coming into your image, which you wouldn't want. Moving on, you have saturation bands. There's an image here of saturation band placed in slightly the wrong position. That's what you don't want. So what you would do is place your saturation bands over the areas of large motion. So for example, this is a sagittal image of a spine. You'd want your saturation band exactly probably 90 degrees covering the chest and abdominal area, and then that would then reduce out that area from the image and not include it, and then remove the artifact from the spinal imaging which you would be looking for. The saturation bands avoid the signal and suppress all of the detail in that area, and that will give you a nice clear image. So you could alter the phase encoding. That does have time penalties, which is a disadvantage, especially when you're imaging pediatrics. It's always a consideration. You can also use a cross-sectional navigator. This is commonly placed on the dome of the right diaphragm on the navigation aspect, and this is imaged in real time, and then it triggers, and the lowest threshold of movement when it's imaging the tissue of the chest and the tissue of the liver. This also has quite a time penalty because it's only acquiring in a very, very small window. However, it is worth investing in as you get the nicest images, and they work out really well. Usually best used again on T2s where you get a lot of forgiving time for the longer RF relaxation times. And in a similar vein, you can use cardiac gating. This is usually only beneficial if you are imaging the heart. This works by triggering the phase encoding steps at a fixed time in the cardiac cycle, a little bit similar to our navigation, the prospective navigation. This can be inefficient if your patient is quite unwell and has an inefficient heartbeat and cardiac cycle. And the gating methods are inefficient because only the data collected in specific parts of the cycle can be used, so it can result in a really long scan time and really long TRs. And then finally, in the respiratory artifacts list, we have external prospective gate triggering, which is bellows. We tend not to use these actually because it's a band physically wrapped around the patients. For pediatrics, we find that can be quite scary. They become a little bit anxious, and then that tends to affect the scan. So we don't use that as much. But in adult patients, I think they are quite helpful. New technology these days, the respiratory sensors are actually inbuilt into the scanner and can trigger automatically if it feels that that's what's required as you're scanning, which is fantastic for normal size adults whose chest lies in the exact right place when you're scanning. However, when we're scanning pediatrics, we scan a variety of ages from very small to adult size. So for a lot of our patients, that probably wouldn't work as their chests will not land in the correct place. But I can see how that would be very helpful for adult centres and adult populations who are generally mostly about the same size, and their chest will be in the correct place in the scanner. So moving on, I'm just going to talk about some truncation artefacts. These are sometimes called Gibbs ringing, and these are quite subtle, so I hope this is reflected in the images. Apologies if it's not clear. So along these yellow lines, yellow arrows, there are some very faint lines. And we usually find these near the sharp tissue boundary interfaces, so in the cranial vault, and then the artifact appears over the parenchyma. And they cause a ring-like appearance on the imaging. Particularly in some scans, like the image of the spine with the pink arrows, it can cause some mimics or false positives, as they can appear like a syrinx in the spinal cord. A way that these can be fixed and reduced is to increase the overall spatial resolution. That does have some downfalls, as you can lose SNR as a result of that. We can also add some filters, Hanning filters. This reduces the effect, but can reduce overall CNR and can also increase the risk of some chemical shift artifacts into the images as well. So it's a bit of a balance. This type of artifact is generally one that appears more of a problem in the higher field scanners. So in your 3T, and if you're lucky enough to have 7T, this tends to be more of an issue in those areas. Moving on, something which I'm sure all of us have seen in our time. This is quite a common problem: aliasing, or sometimes called wrap. This applies to anatomy that's outside of the field of acquired imaging, and then when the image comes out, those areas that are outside have been sampled and have been entered into the K-space and appear on the image. This could potentially obscure pathology, so it is quite important we can repeat. It does depend what you're looking for. For example, if you're looking at pituitary pathology in this image, it might not be too much of an issue. However, I do like, personally, because I'm a perfectionist, to produce images without the aliasing in. How to fix it? What we can do is increase our field of view. That does tend to increase SNR. And again, oversampling, so acquiring extra data outside and then discarding it from your overall image. This also does increase SNR a little bit and also adds a time penalty. Moving on, I'm going to take you through some foreign bodies. We see expected foreign bodies all the time on our imaging. So for example, intracranial catheters, different types of implants that patients have, and dental, especially in pediatric population, we get a lot of teenagers with fixed braces, which can be quite problematic for imaging. This is a common occurrence for us, and we do see these all the time. So here we have an example. This is the same patient, but just different slices and the different effects that the braces have on each of these sequences. So the first image you have here on the left is an example of an ADC, part of the diffusion scan. And then we have a gradient echo in the middle and a T2 just on the right at the end. So susceptibility artifacts are the worst with long echo times. So what we'd have with the diffusion and also the middle gradient base scan. So it gives the spins more time to dephase, and the spin echo sequences, they use 180 degrees rephasing, and then that reversal cannot rephase to minimize the signal loss, which is why on the gradient type scans it always looks a lot worse. The best sequences to get around these artifacts are a combination of spin echo and a short TE, and these are usually found in fast spin echo techniques. So this T2 is a good example of that. So another way you can minimize is decreasing the slice thickness. That can also help. And a slight reduction of the artifact can also be achieved by using a higher bandwidth technique. This can then, as a downside, increase the risk of chemical shift artifact. So it's important, again, to balance what you need to get the best images required to answer the clinical question for these cases. So a couple of recent examples. This is, again, a localizer, very quick gradient echo scan. So the dark susceptibility artifact is evident in 2 planes. This patient had no indication of any previous surgery, and visually there was nothing on this patient before going on the scanner, so you'd be very concerned. So brought this patient off. It does look like it's in the right ear IAM area, so had a chat to the family. Definitely no surgery. They don't know if the patient didn't have any piercings or anything like that. He's very young. So we asked our ENT colleagues, so the patient was under GA, so we didn't want to wake them up at this stage. And I had a little look in the ear, and you could just see something in the ear canal. So our ENT colleagues kindly came to help us out with a little scope, and it turned out this patient had the back of an earring sitting in his ear canal, which they kindly removed for us, and then we could get on and do the brain scan without any further problems. And we gave this back to the mom, wondered had she lost this, and she had no idea it was there. So we were a diagnostic and therapeutic scan that day, which the mom was very pleased about. Another case study, this was quite recent actually. So again, this is a fast haste localizer. This patient was for a brain and a spine. We'd already imaged the brain. Again, no history of any surgery, not had any abdominal problems that we've known of, nothing before we looked on the gown. There's nothing on the gown. There's definitely some susceptibility artifact visible. So without any further information, we brought the patient off and we did a quick x-ray, which showed these 2 little round dots, very unusual. And then after a little chat with the mom, we found out that this patient had one of these toys, which was a set of magnets that are meant to stick together and make shapes. And please, if any of you are parents, do not ever buy these. The mom did say she'd taken them off him because they kept going missing because they were swallowing them. So this patient then had an overnight stay and had some monitoring of these magnets. And over the next 3 months, they are still there. So we're still in progress, and I don't know if this patient's probably going to need surgery to have them removed because they've not moved anywhere. So that's still ongoing. Please don't ever buy these toys, they're the worst. This next case, again, a recent one we've had a little spate recently. This, again, same sort of artifact, susceptibility, no history of surgery. So again, we brought the patient off, did an x-ray in a couple of different positions just to be sure, had a close look, and then I realised exactly what that is. This is the pen nib. So this patient had swallowed a Bic pen nib. So we informed the parents, and I'm actually not sure of any follow-up that's happened with that, but we weren't able to continue with the scan with that in place because we didn't know if it was going to cause any damage. And finally, moving on to some technical artifacts. So here's an example of hardware issue. So image A and B are demonstrating something that is called a zipper artifact. This is usually something involving electrical equipment, so anesthetic machine too close to the gas lines, a fault on something electrical we've had before, and blown light bulbs, although these days most of our light bulbs are LED, so this has definitely reduced in frequency happening since that change has been made with the more modern LED light bulbs. And then image C and D, we have herringbone artifact, so some very neat, looks a little bit like corduroy effect on these images. So this is a case-based abnormality, and it's also called a spike artifact. So this can signify a problem in the case base, or what we've had recently, and this has caused, is some broken parts in the scanner table. When we have these, we also check for RF interference again, we checked all the doors. However, these were caused by a fault in the scanner table. Some parts were replaced and this is now solved. So if you ever see herringbone artifact, this is a case-based abnormality and can sometimes be caused by hardware faults. And finally, this is a DTI artifact. I'm not sure how many centres regularly do DTIs. We do them quite often for epilepsy and sometimes for tumour imaging. So again, this is a bit like the air interface problem we had with the diffusion scan from earlier. This is susceptibility artifact that arises from the boundary between the tissue and air in the sinuses, a bit like before, like I said. They have different magnetic susceptibilities which affect the local magnetic field which causes the distortion. When the phase encoding is applied right to left, it is a bit more apparent, like as shown by the red arrows. So what we did was shifted the phase encoding for this scenario, and that artifact does still appear, shown there on the second image on the right with the green arrow. But applying it in this direction, we maintain the symmetry of the brain, and the artifact does still, but it's not as disruptive to areas that are really important for when we're looking at for the tracts, when we're acquiring the DTI images. So although still there, it's not as disruptive. So I hope you enjoyed my whistle-stop tour of artifacts and some pointers on how to solve them. I hope it was okay physics. I don't delve into the physics too much. I'm really sorry, it's not my strength, but delve into it a little bit as a radiographer as much as I can. So I hope you enjoyed, and also the case studies, those are my favourite parts. So thank you very much and I appreciate your attention. I'm sorry I'm not there to take any questions, but my email address is on the screen, so please feel free to drop me an email if you have any burning questions. And thank you so much. And again, thank you to Spin for asking me to be involved and for setting up this format to promote teaching and learning in such a wide field. Thank you very much.